morning, everybody, and thanks very much for coming and giving us a part of your Saturday. I know everybody's time is valuable, so we appreciate you spending some time with us. I'm going to go over a few things today. I will not cover everything having to do with research regarding MS, just focusing on some of them and focusing on some that are also relevant to what we're doing at our place as well. And those are my disclosures that could be potentially relevant. This is next couple slides are just the slides showing us some of the studies that are presently available and recruiting, and I'll talk some about those that are finished as well. And we broke them down into categories, based on nature of the MS at the time, aggressive MS, and then also some that are not treatment trials, exercise trials, trials specifically for newly diagnosed patients. Some of these, for example, I'll talk briefly about the central vein sign. COVID-related studies you've already heard about, I'm not going to talk about anymore. And some that are seen in healthy volunteers, as Dr. Alvarez mentioned. He did not mention the DREAMS and RISE studies, which are looking at risk factors in very early MS and first-degree relatives of those with MS. And these are asymptomatic, usually kids or siblings of people with MS, age 10 to 30. And we're trying to come up with an easily adopted way to actually screen people who are at relatively high risk. So trying to come up with an algorithm defining what the nature of risk is in these people who are relatively high risk because they carry genes that are relevant to MS potentially. And then we have a number of biobank studies. And I listed down on the bottom the phone number for our research studies if you ever have any questions. And we can always send consents and other things like that to you if you are interested in particular studies. So I would like to talk about a few specifically, and a couple that are treatment trials that are completed, and those are notably the DISCOMS study. I'm going to talk in detail, not about today, just give some background information about it, but we'll be doing a webinar on the 13th of June at 9 o'clock in the morning. It's a Monday. You're welcome to sign up for that. It's through Eventbrite. And the DISCOMS study is the study that we've been performing for the last 6 or 7 years, looking at discontinuing disease-modifying therapies in people as they age. And so we'll have the results of that in about a little over a month. I'll give just a little bit of background about that today. A little bit of talk about obinutuzumab. This is another medication in the same category as rituximab, ocrelizumab, and ofatumumab, or Rituxan, Ocrevus, and Kesimpta. So this one doesn't have a fancy name yet. And then ongoing studies, I'll talk mostly about the Bruton's tyrosine kinase inhibitors, a couple of others as well. I mentioned RISE and DREAMS already, and the other ones I'm not going to really talk about much. So regarding discontinuation, when someone is first diagnosed with multiple sclerosis, there are a number of questions that revolve around what does this mean? What will happen to me over time? What should I do to eat a healthy diet, exercise, etc.? But a big question is, should I use a disease-modifying therapy, a DMT? And if so, which one is important for me? And it's always going to be an individual discussion for that particular person regarding a number of different aspects of it. A big issue is, of course, whether or not insurance will cover it, if they force you to go through step edits or fail first therapies. But a major question that we don't talk about much at the beginning is, when should I stop using this? Or maybe the flip side of that is, how long do I need to continue to use this? And so this question has been mostly unasked in our world because for many years, of course, we didn't have any therapies prior to 1993. And we got so excited about having, we were making sure we were treating people, but we never really asked a fundamental question, how long do we need to do this? And so that is the basis of the DISCOMS study. And it's based on these principles. As you've already heard a little bit before, there are less actively inflamed lesions pathologically as people age, and their progressive patients have totally different pathology than people who are younger with relapsing MS. There's diminished repair and remyelination capacity in the CNS as you age. There's reduced relapses and reduced new MRI scan changes as you age. There's a transition for an unclear percentage of people to a phase of greater disability with progression independent of relapses and with not very many relapses. But more importantly, even is that the presently available disease-modifying therapies have been demonstrably shown to have less benefit as people age. And there's an increased risk of infections and other things that are potentially relevant, such as cancers, diabetes, hypertension, et cetera, as people age, which might put people on these medications at higher risk as they age, so that the risk profile may change as well over time. In addition, when we asked people in a survey to NARCOMS, North American Research Committee on MS, and you can survey people, the 30,000 or so people in NARCOMS, we asked a very simple question of 1,000 people, almost 400 answered the survey, and asked them a simple question: would you be willing to consider a trial off of disease-modifying therapies? And the people were targeted were relatively older, 56. They were still on therapies. Most had relapsing MS. They mostly were still taking their current MS therapy for over 5 years. Many of them were still on older medications like the injectables. 2/3 of those people said that they would not consider a trial going off disease-modifying therapies, reflecting, I think, a great fear that if someone, especially if they were stable, would not want to potentially go off a medication and run the risk of having new disease activity. On the other hand, there's many people who maybe have never been treated, or many people who are really quite tired of taking their medications. And for those individuals, and in this case, at least up to 1/3 of people, they would be highly interested potentially in going off of therapy. So this was an unanswered question and remains an unanswered question, although observational studies suggest that there's probably a significant number of people that could safely go off medication. So based on this query, this need in the community, we devised the DISCOMS study. And it was performed in 20 centers in the United States, enrolled people from 2017 through 2021. It was randomized 1-to-1. This is the first randomized, controlled, blinded discontinuation trial. Half the people were randomized to stay on their drug, half to randomized to go off. It was rater blinded. The people who were actually deciding, did you have a relapse or did you have a change in your disability, were blinded. The MRIs were read at the Cleveland Clinic by a blinded person who just read the scans, didn't know who was who. It was a pragmatic study. It was funded by PCORI, Patient-Centered Outcome Research Institute. So thank you very much, all of you. You paid for the study. And the National MS Society, for those of you who contributed there. Insurance, however, was required to pay for MRIs and disease-modifying therapies. That is, this was a real-life, real-world study. And consequently, we didn't necessarily have a standardized protocol at every location. So we didn't have quite as many MRI outcome measures you might see in some of the pharmaceutical-based studies. Patients came to see every 6 months, and the brain MRI scans were done at baseline, then at 6, 12, and 24 months after randomization. So that's just generally the way the study was done. And there was a unique factor to it, though, and that is that, I'll come to in a second, in the way we assess things. The primary outcome measure was a combination of whether or not you had a relapse, and this was a documented true relapse, not a pseudo-relapse, and or a new brain MRI scan lesion. Secondary outcomes were change in disability using the EDSS, Expanded Disability Status Scale, Extended Disability Status Scale. And tertiary outcomes were a number of patient-reported outcomes, for example, a cognitive study, the SDMT, PDDS, which is a patient-derived version of the EDSS, and others. The data center was in Alabama. And interestingly, the hypothesis then in this study, we weren't trying to prove that one thing was better than another. We were trying to prove that going off medication was not inferior to staying on it. And that's a different statistical question. And so the hypothesis was that discontinuation is inferior, and we were trying to disprove that. So it is a slightly different way of thinking about it. When you do studies with a new drug, you compare it to a drug that's already on the market or maybe to a placebo. In this case, we're just trying to show it was not inferior. It is different statistically. And you have to try and use what's known as an inferiority analysis with a cutoff of a certain percentage of worseness that you would accept. And for a variety of reasons, we opted for 8% difference in the primary outcome measure. The others were just, is one better than the other? And this was an intention to treat analysis. That means you took everybody. And then you could also do a secondary analysis based on, well, who actually finished the protocol correctly? And that's a per protocol analysis. We actually did both, and the results will hopefully come out to be the same. And this is how this is a different kind of study. So as opposed to trying to show that something is better than another something, then you would say, is this just not inferior? So if this is our line showing the basic thing, in this case, staying on your medication, and then we'll say, we'll accept, in this case, 8% more of activity, plus whatever the error range is, and that's what the bars are around the dot. You could show non-inferiority if you're within that range. That is, this is the new therapy, in this case going off therapy, with its error bars, and it's completely within the non-inferiority zone. Or you could show that the new treatment, in this case going off therapy, is inferior. It's well outside the non-inferior zone. Or you could show that non-inferiority is not demonstrated. That is, it may be inferior, it may not be inferior. So it's a little trickier. It's a different way to think about things, but this is what you do when you're trying to show that something is really not different from a different, whatever the standard is, in this case, staying on therapy. So the participants are all noted here. I won't go over this in detail, the inclusion and exclusion criteria, but essentially people had to be 55 or older and no relapse for 5 years, no new scan change of any type for at least 3 years, and then a variety of other things. And we took people on all their different medications and of all different types of MS, and there was no maximum age, just a minimum of 55. And this is what this is the numbers of people that we saw. We screened almost 6,000 people, of which 5,300 were excluded just because they didn't fulfill the criteria to get in. They might have been too young or had a recent relapse or had been off therapy. They had to be continuously on therapy. But ultimately, 4,500 did not meet the inclusion criteria. 434 just said, no, thank you. Other people were excluded for other reasons. We ended up with 259 total, 128 allocated to stay on their medication, 131 to go off their medication. And this is just the demographics. This is who's actually in the study. And all the subjects are noted on the left, and those who continue and those who discontinue are noted on the right. And there are no significant differences between any of these. And here are all the different medicines that they were on, the different types of phenotypes. Notably, the mean EDSS, the Expanded Disability Status Scale, showed on this 10-point scale a moderate level of disability, certainly not severe on average. But we had people who were wheelchair bound in this study. And the years from symptom onset were about 22. And notably, look at that age. 63 is the average age in this study. The average age in the studies for all the relapsing MS drugs that have been approved is usually about 36, 37. And for progressive MS, the average age is usually about 47. So this is a distinctly different population of people who essentially have never been studied in MS studies in the modern era. So this will turn out to be the largest study ever done so far in people over the age of 55 with multiple sclerosis. And as I mentioned, we'll have all that data on June 13th. And notably as well, there's a study in France, another study in Holland, also randomized controlled discontinuation trials, similar sizes, slightly different orientations though. The French study is only in progressive patients, 50 plus, no relapse and no scan change for 3+ years. The Netherlands study, the Holland study is very interesting. They're taking people over the age of 18. So you could have been diagnosed at age 13, have 5 years of therapy, but be stable during that time, and go into this study and potentially be randomized to go off drug, which is interesting because I think there's going to be a high risk of having new disease activity. And both of these studies will be for a longer period of time as well, a couple years at least, and they're noted there. They're not going to finish for a couple more years. So all of these are different populations. We'll have a much better idea at the end of these for different populations what the risks are if you wish to consider a trial off disease-modifying therapy. So we'll have that data June 13th. You can sign up through Eventbrite. Ublituximab. Ublituximab is a new drug in the same category as rituximab, ocrelizumab, and ofatumumab. And there were phase 2 trials and now completed phase 3 trials, the Ultimate 1 and Ultimate 2. And I'll just show you a little bit of that data. And we've seen variations of this over time, several times when we've given these talks. about the B cell therapies, the anti-CD20 therapies. And what the CD20 represents is one of several different markers that may occur on the outside of the B lymphocytes, one type of white blood cell that we've heard a lot about today. And the notable thing is that some of these markers, these proteins, which actually stick through the cell surface, some part of the protein inside the cell, some part of the protein outside the cell. These are just markers then on the outside of these cells. And every cell in your body pretty much will develop and change and differentiate over time and expand and contract and ultimately get to a point where they stop that. And what they do is their job. In this case, for B cells, they grow up to become plasma cells, which make antibodies, as you heard earlier from Dr. McKay. At different times in this development, they'll have different cell surface markers on them. And you can utilize that information for the therapies that we're talking about. And the therapies we're talking about today are really the CD20 therapies, rituximab, ocrelizumab, ofatumumab, and obinutuzumab. So the obinutuzumab represents the latest, and there are other drugs as well. They're originally developed to treat lymphomas, because lymphomas are B cell lymphomas typically. Some are T cell, but most are B cells. And they have the same marker on the outside of the cell. So 30 years ago, the first one, rituximab, was developed to treat lymphoma. And then ultimately was used for rheumatoid arthritis, a variety of rheumatologic conditions, and then later multiple sclerosis. And so this is the B cell surface here, and this is the CD20 protein that goes in and out of the surface. And these are all amino acids. Proteins are made of amino acids, and they circle, go back in and go back out. And all of the different locations where the binding occurs, the epitopes on this circuitous route here that the protein takes, you can have these different antibodies made in the lab that interact in different locations. And the thing that is notable is rituximab and ocrelizumab, they really have a great deal of overlap, almost 100% identical overlap with where they intersect with this molecule. Whereas ofatumumab has a couple of different locations in blue here that are completely separate. Obinutuzumab, also in green, has two places, partly overlapping with the rituximab ocrelizumab area and partly overlapping with the ofatumumab. So all of these will interact in different ways. They will end up destroying or removing, depleting these cells in slightly different ways. And the notable thing about obinutuzumab I'll go into now. So this have several different changes. It has significantly enhanced killing by what's called antibody-dependent cellular cytotoxicity. And it is a better killer. This will be very effective and is being studied extensively in lymphoma and may well be a better lymphoma drug than rituximab. It is also seen to be very helpful in those cells that don't express a lot of this CD20 on the surface of the cell, so that it can actually do a better job of identifying more of the cells. Again, for lymphoma, a big deal. And it binds to a novel epitope, as I showed you. And in the phase 2 studies, and this is about 48 people, and they used a couple of different doses. This is taken by IV every 6 months. You have a couple different doses to start, 150, then 450 2 weeks later. And then after that, 450 milligrams every 6 months. And notably, a very short infusion time of only about an hour, which is different from ocrelizumab and rituximab, which are very long infusions. And they showed that compared to baseline, there was a substantial reduction. This was having to do with the lesion volume that could be seen. Lesion volume is one of the things that predicts disability over time. This was a phase 2 study, mostly MRI outcome measures. And at 24 and 48 weeks, you can see there's a reduction. So there's shrinkage, which we expect to see with these treatments. And the relapses compared to baseline were dramatically reduced, over 95% reduction compared to baseline. So they also looked at so-called NEDA, and NEDA is no evidence of disease activity. And they looked at this at 24 weeks, that is 6 months, and showed that there, in terms of relapses, disability progression, new enhancing lesions, and in new enlarging lesions, about 74% of people had none of those things. So over at least a 6-month period of time, 74% of people achieved what we call NIDA. On the basis of these phase 2 studies, they went on to phase 3 studies, which are focused on safety and efficacy, and much larger, mostly relapsing patients, a small number of so-called secondary progressive MS patients. Here's that regimen that I mentioned, 150, 450, and then the 450 every 6 months, and compared it directly to Aubagio, one of the standard oral medications, which is felt to be a moderately efficacious approach. And typically, the newer drugs that come on the market will compare to one of the interferons or to Aubagio. And showed that in the 2 different studies, almost a 60% and 50% reduction in relapse rate annually. Again, a 95% reduction in gadolinium-enhancing lesions, the active lesions on scan, compared to an active comparator. The NIDA, now this is over 2 years, not just 6 months, about half versus just 12% achieved NIDA with Aubagio. A similar number had confirmed disability. This is one failing of this phase 3 studies. They didn't really show less disability accrual compared to Aubagio. They did have a slightly greater number with less disability who actually improved, however, in the EDSS. So on the basis of this, they've gone to the FDA. I don't know what it's called a PDUFA date is. That's the date the FDA must say yes or no. And I can't tell you what PDUFA stands for. But we'll have that relatively soon, probably within the year. And we'll see if this adds to the armamentarium. And it has some advantages and some disadvantages compared to the other CD20 drugs that we use. In a related fashion, there's a whole new family of medications that is being studied very aggressively right now with multiple drugs in the same class of so-called tyrosine kinase inhibitors. And tyrosine kinase, anything that says A's is an enzyme, and it makes metabolic reactions occur faster and better. And tyrosine kinases essentially take a phosphate group from here and move it over here. That doesn't sound like much, but that changes everything inside cells and sometimes outside cells to have the cells proliferate more or less, differentiate more or less, turn on or turn off more or less. And so this simple thing of moving a phosphate group from one area, one molecule to another has a profound effect on cellular function. And you can have tyrosine kinases all over your body and do. Some are very specific for certain cells. Some are much more broadly specific. And then you can also have inhibitors of these, some of which bind very tightly and very exclusively, and some of which are more promiscuous and maybe don't bind quite so tightly. And so this whole family of medications has been used in cancer therapies, that is tyrosine kinase inhibitors, have been used in cancer therapies, as well as in the rheumatologic world and now in our world. And there are 2 that have been studied. One is just the nasitinib family. These are targeting mast cells, part of the innate immune system that you heard about earlier, and macrophages, also part of the innate immune system, and microglia, also part of the innate immune system. And microglia are very important because these are immune cells that live inside your nervous system. They're the only ones that live inside your nervous system that are really professional immune cells. And other organs like your kidneys, livers. Livers have Kupffer cells that are very similar that live inside the liver. So sometimes the immune system travels all over. Sometimes they're very distinctly in certain areas. There's also the Bruton's tyrosine kinases, which are the ones we'll talk about mostly. These are on a number of different cells, except for the T lymphocytes, natural killer cells, and plasma cells. These are more widely used throughout the hematopoietic or the blood cell system, but especially within B cells. And multiple of these are being studied right now in both relapsing MS and progressive MS, because these are also utilized in microglia, just like we talked about up here, these ones that are inside the nervous system. The microglia pathologically seem to be much more important for progressive MS and are associated with a significant degree of activation at autopsies in people with progressive MS. So that the great hope with this class of medications is that these will be useful in turning down the different type of inflammatory events that are going on in those with progressive MS, for which there is the greatest unmet need in the treatment of MS. And so this is just a cartoon showing that the BTK, Bruton's tyrosine kinase, you can see this is the B cell receptor here. It gets activated. These molecules get made. The BTK takes the phosphate, takes it from here over to here, and then there's a downstream cascade of events that occur, changing the cellular function of the B cell. And these are drugs presently, all these utinibs and itinibs that are being studied right now in multiple sclerosis and other conditions. These are the three that are in phase 3 trials. They're mostly being studied in MS, and there are others as well in phase 2 and phase 1 studies as well. And this is just one study looking at masitinib, the first one that I mentioned that is seen on mast cells and microglia, showing in progressive patients a significantly less amount of progression of disability in their phase 2 studies, looking at that as their primary outcome measure. And on the basis of this, they're also doing phase 3 trials, which should be reported soon. This is with some of the Bruton's tyrosine kinase inhibitors. This one is evobrutinib and is in relapsing MS, a phase 2 study. And they looked at total number of lesions on scans, relapse rate ratios and annualized relapse rates, and at 24 and 48 weeks with multiple different doses. And the doses are all noted here compared to placebo. You can see a significant reduction, especially at the higher doses at week 24. After week 24, the people on placebo got converted over to being treated with the 25 milligrams per day. You can still see that there's a gradient with the higher dose doing a better job at reducing relapses. And had a sort of a similar effect in comparison to the Tecfidera dimethyl fumarate that was the comparison. Can also measure MRI outcome measures, and this is important. These are slowly expanding lesions. This is something that might be, again, important in progressive MS, where we tend to see these lesions slowly enlarge over time. And the higher dose showed a substantial impact on reducing the number of slowly evolving or expanding lesions in progressive MS patients. And this just showed, and this is with tolebrutinib, again, at a higher dose, and this is new enhancing or active lesions on the scan, that you can see a substantial drop-off compared to placebo. So 4 or 5 different drugs being studied right now. We're doing studies with many of them, at least 3 or 4 of them in this family, to look at both relapsing studies as well as progressive MS. And this is just some safety data showing that these oral drugs are very well tolerated overall. Just wanted to remind people, I've talked about this several times, we're still enrolling for the autologous hematopoietic stem cell or stem cell therapies in younger patients, typically with highly active relapsing MS, unresponsive to traditional therapies, to compare stem cell therapy to best available therapy, or beat MS. And this study is ongoing. It's funded by the National Institutes of Health and Immune Tolerance Network. And the stem cell study, if you get randomized 1-to-1 into that, that would be covered by the NIH. If you are randomized to best available therapy, that would be covered by insurance. So this study has enrolled not that many people so far. The goal is about 150. We've enrolled about 20 so far. And this is a very important but smaller subset of patients who are potentially going to benefit from this. This is just from ECTRIMS late last year, showing in a comparison over time in those with active MS getting stem cell therapy versus regular disease-modifying therapies, that even in so-called active secondary progressive MS, people progressing but have active lesions on their scan or maybe had a recent relapse, that they do benefit in terms of what happens to the EDSS as opposed to worsening. There actually was a somewhat improvement in the people who got stem cell therapy. Just a couple things, and I'll breeze through the rest of these pretty fast, having to do with diagnosis We still have some trouble sometimes diagnosing people because there's a lot of things that cause little white dots on brain scans and a lot of things that may cause either very vague symptoms or symptoms that overlap, like Dr. Gross described with relapses. One thing that might be useful is the so-called central vein sign. And this is just a technology that is available that you can actually see the veins that may go through the lesions of MS. We've known for many years pathologically that the actual location of the MS plaque, the acute MS lesion, is that it's wrapped around veins. It is perivenular. And you can actually see that on the MRI scans. And if you look here, so there's a lesion there, you can see the vein going right through it. You can see the vein going right through it. And many studies have looked at, well, do other things do that as well? And people have come up with various thresholds saying, well, if 40% or maybe 50% of the lesions have this vein going through it, then it's much more likely it's MS than not. Or maybe if at least three of the lesions on a first scan have that, then it's much more likely MS than not. And ultimately, about 45%, if you use that as a cutoff, has a high sensitivity and high specificity for MS. In this particular study, the notable thing is that the lesions 12 months later still have that vein sign that you can see. So this is a persisting effect as well. 81% still had that persisting. And these are some of the sort of typical lesions that we see. You know, these lesions in the corpus callosum, in the cerebellum. Here's another, this is a really good example of a central vein sign, but also this rim effect here, the magnetic rim that is seen. This is also being studied. This is associated with rim of iron, oftentimes reflecting pathologically a chronic active lesion. And this is very important because these are ones that are felt to be potentially involved not only with acute attacks of MS, but also sometimes with progressive MS pathologically as well. So this might be an outcome measure that we start seeing more as well, especially in progressive MS studies. And so we are participating in the CAB study. And this is a really important study because anybody who's got a question of MS, maybe they have MS, maybe they don't, they have little white dots on their brain scan. And to use this explicitly in that population, because it's sometimes extremely difficult to tell the difference. Going to be 200 patients total, 100 in each group, age is listed there, and look at people with typical symptoms of MS and then atypical symptoms. Maybe they have other demyelinating disorders, maybe they have some non-specific symptoms, or sometimes even no symptoms, but they have dots on their brain scan. So this is an MRI-only study. So the last thing I'm going to talk about is Epstein-Barr virus. For many years, there has been a major question as to whether or not infections in general are related to the risk of developing MS. And a major family that would be considered likely candidates are the herpes family, because the herpes viruses, and there are many different ones, including Epstein-Barr, the herpes viruses are known to be infecting B lymphocytes and other cells of the hematopoietic cell system. But in addition, travel in and outside of the nervous system. If we know, for example, that many of them will infect the nervous system and they will come and go. They don't leave your body. So they have a number of characteristics that are potentially very relevant to development and maintenance of MS. So we know these infections persist latently in B lymphocytes. There's an increased risk of MS after mononucleosis, which is caused by Epstein-Barr virus. We know there's elevated serum antibody titers of EBV nuclear antigens, EBNA, in MS patients compared to controls. There's the presence of EBV in some, but not all pathological studies, and I'll show you one study that I participated in. And notably, the first vaccine trial for Epstein-Barr virus with Moderna, same kind of vaccine, but a different virus as being used in COVID, started on January 6th of 22. This would potentially be a very important event should this study show an impact on multiple sclerosis. So this is just one example. This is a study I participated in because I run the tissue bank, and we gave to our colleagues in the United Arab Emirates over 100 samples of MS autopsy tissue, 21 controls, and they looked for evidence of the DNA of Epstein-Barr virus actually in the brain. And in 90% of the MS brains, you could find evidence of EBV compared to only 24% of the controls, so a substantially different amount. And they also then looked for different other viruses in the herpes family, and none were positive for these. None, zero. So even though the herpes viruses, these other ones may also infect and live in the brain, none were seen there. Epstein-Barr virus, 90%. So studies like this and other studies have suggested that there's some role, probably not a direct infection, but something having to do with a latent effect or an effect perhaps on B lymphocytes. In our study, you could find EBV not just in the B cells though, but also in astrocytes and microglia inside the nervous system. And those are support cells, and I've already mentioned microglia, which are scavenger cells and also can exist in a hyperinflamed state, especially in progressive MS. So all of these things raise that possibility, but you may have heard recently that there was another study done by Dr. Asherio and his colleagues at Harvard looking at what is the relationship between Epstein-Barr virus, seroconversion that is being exposed to that and developing an immune response against it, and development of MS. And they have done some very interesting studies, and this is the second or third time they've gone back to this well, but they did it in a very elegant way. So this was just published in Science a couple weeks ago. And they looked at 62 million serum specimens. That's correct, 62 million serum specimens from the Army. The Army is very good, especially since HIV, at collecting blood, storing blood, and testing it for viruses. And so these, since 1993 to 2013, they collected fluid over that entire period of time. And they then said, okay, we want to look at people that developed MS, compare them to people who didn't develop MS, and also compare people who are seronegative, since many people, by the time they get to the Army, have already been converted to, from exposure to Epstein-Barr virus, have developed an immune response against it. So they wanted to look at people who were seronegative when they entered and had multiple different time frames that they could test, and compare the people who developed MS compared to those who didn't develop MS, who were seronegative especially. That's the most important thing from this study. And they found a number of things. Number one, amongst this group of all these different people, mostly young men, as you can imagine, ages listed there, and racial background listed there, they found 801 cases who were EBV, they found 801 cases of MS patients out of all of those. And they had 1,566 controls, so like 2-to-1 controls. Of the 801, only one person at the end of the study had not seroconverted to Epstein-Barr virus. So only one person who was Epstein-Barr virus negative developed multiple sclerosis. At baseline, they had 35 cases and 107 controls who were EBV negative, and 34 of those 35 became positive at the last follow-up, all before developing MS. So that one person was actually in that group. So the interesting thing is here then. So in blue are the people who did not develop MS, in green the people who did develop MS. So these are all seronegative at the start. And you can see quite a few people converted. They got exposed to Epstein-Barr virus. That's, you usually get exposed between about 10 and 20 to 25. And quite a few of them got exposed. But if you didn't develop MS, only about 57% actually were seroconverting. Amongst those who actually developed MS, essentially all but one, 34 of 35, seroconverted. So if you take all the people who seroconverted, there's about a 32-fold increased risk of developing MS. And if you look at people who were baseline already positive for that, it was a 26-fold increased risk. These are tremendously high numbers. The biggest impact of any one gene that we're aware of the 200 plus genes associated with risk of developing MS, is about a 3-fold increased risk. This is, 8 to 10 times that. So this is perhaps the largest impact that we can see. And they again looked at other viruses, and this is CMV here, showed no impact and showed no difference between those who got MS and who did not in terms of seroconversion. So they also had controls. So this study has sort of reinforced the important finding that EBV is probably necessary for, but not sufficient by itself to actually develop multiple sclerosis. Because the vast majority of people in this room who have MS or who don't have MS have been exposed to this virus. By the time you hit your 40s or 50s, 97, 98% of people have been exposed to this virus. So most people exposed never develop MS. There have to be other factors. And those other factors, some of which we know, such as other genes, smoking, vitamin D, toxic exposures, and others are relevant. But it's necessary but not sufficient. But this is the strongest indirect method of identifying what role this might play. So that's all I have to talk about today. We appreciate your time coming in. We're going to take a small break, and then Dr. Gross and I will come back. We'll be happy to answer questions. So if you have some questions, please write them down, and then we'll be able to go through those and answer them when you come back. Thanks for coming.